Okay, let me get you into the mindset here. The setting is Egypt. The year 1936. Legend speaks of an ancient Egyptian pharaoh who had hidden a powerful relic in a city consumed by the desert in a sandstorm long ago, and it has been the obsession of archaeologists ever since. However, one archaeologist professor has finally discovered the whereabouts of the headpiece of the staff aureus. A golden staff, it is said, that can lead one to the exact location of the pharaoh's hidden chamber. I know what you're thinking. It pops right into my head, too. Cue the John Williams! Oh, come on! Can't we just use a little bit of it? Okay, so vancomycin is a glycopeptide antibiotic active only against gram-positive bacteria, such as staph, strep, and enterococcus. And if you look closely, you may be able to spot some ancient Egyptian temples among these ruins. They're purple for gram-positive. One of the most important indications for vancomycin, of course, is in bloodstream infections caused by methicillin-resistant Staph aureus, or MRSA. In previous sketches, MRSA is always associated with a merciless golden staff-wielding pharaoh. Well, we brought him back. He's the guardian of the relic that has fallen into the hands of our courageous and undeniably attractive professor. Also, whenever something has MRSA coverage, we usually include the words "no mercy" somewhere. And here, we'll carve it in the front of the temple from which our professor narrowly makes his escape. Take a look at that temple. It's spherical, purple, in order to represent the gram-positive cell wall of Staphylococcus. And what have we got here? He's clutching onto none other than the legendary golden Staph aureus. And of course, our professor came prepared with a getaway van. That looks pretty roomy. You could probably fit the whole Ark of the Covenant back there. Notice that our intrepid professor is using a whip to attach directly to the temple wall as he swings to safety. This is because vancomycin directly inhibits cell wall synthesis by binding firmly to the D-ala-D-ala terminus of nascent peptidoglycan peptides. And if we look carefully, we can see the D-ala-D-ala hieroglyphs carved into the structure of the temple wall. I know what you're thinking. We've seen this D-ala-D-ala motif before. In our previous sketches that toured the beta-lactam antibiotics, we illustrated how penicillins halted peptidoglycan synthesis in the bacterial cell wall. But instead of directly binding to peptidoglycan, penicillins bind to the PBPs responsible for peptidoglycan synthesis, represented by builders constructing the cell wall. That's why the anti-staphylococcal penicillins, such as nafcillin and oxacillin, can be thwarted by staphylococci that alter these PBPs, making beta-lactams unable to bind. We have one of these altered penicillin binding proteins here, represented by one of the MRSA pharaoh's mind-altered minions trying to build the temple wall and trap our professor inside. But these methicillin-resistant staphylococci can alter their PBPs all they want. Vancomycin, like our professor's whip, directly binds to the D-ala-D-ala peptidoglycan structure, inhibiting cell wall synthesis and killing the cell, meaning it's bactericidal. Vancomycin is also resistant to beta-lactamases, those pesky plasmid-encoded guards that were shooting down the penicillins in our previous sketches. And here we have a native guarding the temple, adorned with this ring shape to evoke something encoded by plasmid genes. He shoots darts at the professor, who's desecrating the sacred temple, but, I mean, come on, they always miss. Vancomycin is almost always administered IV, and notice that our professor's trusty whip is made of ivy. Vancomycin is widely distributed in the body, including the CSF, during meningeal inflammation. So vancomycin is often combined with ceftriaxone for the empiric treatment of meningitis. This is because of its effectiveness against penicillin-resistant strep pneumo. We'll include a recurring red meningitis mohawk helmet on our Egyptian native whose beta-lactamases usually confer resistance against penicillin treatment, but vancomycin has got you covered. Vancomycin even penetrates into bone to treat MRSA osteomyelitis, so that's why we've included some fish skeletons strewn in the sand. Remember that vancomycin is one of your big gun antibiotics used to treat serious systemic infections, especially in hospitalized and immunocompromised patients who are at higher risk for multi-drug resistant microbe infections. Additionally, patients presenting with hospital-acquired pneumonia may be at higher risk for nosocomial MRSA infection, and vancomycin can be added to their regimen. So remember, the addition of vancomycin or other MRSA coverage may be important in hospital settings. This is represented by this nurse waiting beside our professor's getaway van, and think of her as our professor's partner, Marion, who kind of just appeared in, one other John Carpenter movie and then disappeared? I mean, what happened to her? Anyways, she has lung stains on her uniform as she coughs from the desert sand. This will represent hospital-acquired pneumonia, but that's just one example of nosocomial MRSA infection. Vancomycin is effective against most staphylococcal species, including Staph epidermidis, which forms biofilms on hospital IV lines and on prosthetic devices like heart valves. Looks like our getaway van isn't quite ready yet, because under the van is the inattentive yet reliable repairman from the Staph epidermidis sketchy micro video. Just like in that sketch, he's covered in gunky biofilm, as are the lines and valves he's working on. While endocarditis caused by methicillin-sensitive strains of staph, such as Staph epidermidis, are often more effectively treated with an anti-staph penicillin, such as NAF, remember NAF for staph, vancomycin is first line for the empiric treatment of endocarditis. Because of its broad and effective coverage of the usual gram-positive culprits, staph, including MRSA, strep, and sensitive Enterococcus species. Let's make the headpiece of the staph heart-shaped to remind you of the empiric treatment of endocarditis. Vancomycin-resistant Enterococcus species are becoming an important clinical concern. Our recurring sketchy symbol for Enterococcus is our purple double bass drum player who's ready to rock, evoking the appearance of this gram-positive Diplococcus. Notice this drumming native is on top of another temple. More like a temple of doom because of its altered peptidoglycan structure. Resistance to vancomycin in enterococci is due to the modification of the D-ala-D-ala binding site on peptidoglycan. The terminal D-alanine is replaced with D-lactate. So, as we can see, our last archaeologist who tried to escape this D-ala-D-lac temple became a permanent addition to that archaeological find, if you know what I mean. Vancomycin is poorly absorbed in the intestinal tract and administered orally only for treatment of colitis caused by Clostridium difficile. Vancomycin might be used in severe cases or those that don't respond to metronidazole, the usual first-line treatment. Students often remember to take a van to the metro when treating C. diff. Our sketchy micro C. diff video took place in a diarrhea-evoking chocolate factory. And we're going to keep the diarrhea flowing here in this inappropriately placed and historically inaccurate Mayan temple with chocolate flowing out of a stone mouth. Remember oral vancomycin for C. diff. Alright, let's finish off this sketch with some adverse effects caused by vancomycin, most of which are relatively minor. Among the more common reactions is the so-called red man syndrome, an infusion-related flushing caused by release of histamine. We'll sketch in an ancient Egyptian statue painted red, and histamine-releasing mast cells will be represented here as a beehive hanging from the arm, ready to degranulate its contents at any second. Red man syndrome can be managed by prolonging infusion or treating with antihistamines. Vancomycin is also irritating to tissue, causing thrombophlebitis at the injection site, represented here by blue vines creeping up the leg of the statue. Ototoxicity and nephrotoxicity are rare with vancomycin, but administration with another ototoxic and nephrotoxic agent, such as aminoglycosides, increases this risk. We're going to sketch in a large gong above the statue, ringing out as the natives sound the alarm. One of the big ears adorning the sacred statue of Anubis is cracked and falling for ototoxicity, and one of the golden kidney-shaped plates topples over, representing nephrotoxicity. And for one final side effect, Vancomycin, along with anticonvulsants, allopurinol, and sulfonamides, can cause a rare, potentially life-threatening drug reaction with eosinophilia and systemic symptoms, or DRESS syndrome. It can occur 2 to 8 weeks after exposure with symptoms of fever, generalized lymphadenopathy, and skin rash. To show the associated eosinophilia, we're going to bring back our EO slingshot shooter with a bilobed mask and a pocket full of pink granules. And to specifically remember dress, let's put this angry native in a flowing eosinophilic dress. Alright, let's wrap this thing up. One last thing to note, 90% of vancomycin is excreted by glomerular filtration. Therefore, plasma level monitoring is necessary, particularly in patients with renal dysfunction or on multiple nephrotoxic drugs, to ensure concentrations are therapeutic. To show the undulating plasma levels, we will draw some vans off in the distance traversing the red, undulating dunes. Alright, let's sum up this sketch. Vancomycin binds directly to the D-ALA-D-ALA structure of peptidoglycan and is effective in treating systemic gram-positive infections, including those caused by MRSA. It's given orally for C. diff, and its side effects includes ototoxicity and nephrotoxicity, for which you might need to monitor drug levels. Overall, I feel like this sketch was pretty good. Definitely deserving of a few subpar yet quality sequels, though more than 2 may be a little excessive.